And Chris, are you happy to introduce yourselves and
Yep.
your purpose? Yeah.
Always happy to speak. As is Margaret. So I'm Chris Carrigan. I've actually got two roles within DataCan. The first is as the PPIE lead, patient public involvement and engagement lead. The second is as the interim chief operating officer as well, which is an interesting mix. Margaret, do you want to just say who you were and where you're from? It's like blind date.
Okay, I'm not sure what's going to come out at the end of it, but that's okay. I'm Margaret Grayson, and I am a member of the PPIE group in DataCan. But today I'm also on home ground today because I chair the Northern Ireland Cancer Research Consumer Forum. Can I just say, I've just been listening to all the things about DataCan. I'm pleased to be part of the PPIE group, and maybe Crystal will talk about this later. I'm pleased to be part of it simply because of the position that the patients have in the decision-making process. And I think that's so important in an organization that's talking about data. And I just think that can be shared with other organizations.
Yeah, I think you're right, Margaret. The model that we seem to have got within DataCan, it's good, proper, active, meaningful PPIE. I think you and I have both seen in the past where an organization has been set up and you put a patient on the group and you put a patient in the back of the room, and it's sort of engagement rather than involvement. You're told stuff, you're sometimes asked opinions, but I think would it be fair to say that the way we've approached this with DataCan is actually completely different. It actually puts you in charge of me, for instance.
Yeah. Yes, and it is very different. Let me just explain quickly some of the background to it. Obviously, it's been said earlier, right at the very start, written into the funding proposal was that there would be this centre of patient and public involvement. And that has been worked through very, very clearly. And I have been seen and been part of that. And it is amazing how there's now 13 people on the group, 13 people who are very different backgrounds, different geography, different gender, different views. And the strength of the PPIE group is that the 13 of us are passionate about data and how data is used. And I think that is important. But then how are we part of DataCan? Are we just names? When you go on the website, do you just press a button and see a photograph of us and hear about us? No, we are actually part of every subgroup, every project within DataCan. And that is for the data use, that is for comms, that is for the commercial. In actual fact, in the commercial, as James has said, we actually have a veto. We're part of two members on the management group, and there are two of us on the steering board. In actual fact, we are voting members on the steering board. Each of the 6 partners, the original partners, actually only have one member. It is not, oh, right, nod your head. It is not a tick box exercise because you have to say, oh, we had involved patients in public. It is actually being part of the decision-making process and not feeling as though you're an add-on. But I'll stop there because I could talk forever. But the basis also should say is that we have a very strong chair in Pete Whitstone. And because we have a PPI lead in Chris, who actually believes in involvement and who listens and works in collaboration and teamwork with the group in the decision making and the going forward, and the same with Emily as our coordinator. So all of that is partnership working, and that's why I think it's working. It's new, of course it's new, but it's growing. Yeah. And
it was interesting to listen to some of the feedback from the breakout group. So I was just trying to scribble down as people were talking. The first point was around risk aversion. The organizations who hold our data are incredibly risk averse because we're a long way away from patients, many of them. And that's one area where we work quite hard in, working with groups such as NHS Digital in England, but Margaret over in Northern Ireland as well, to try and use the patient voice to free up to understand some of that risk aversion and to give them backing to do what we think is the right thing. I think we're quite practical in those areas. And the other one was, just to mention, was the technology side. So there is a perception that the NHS just gives data away to private companies. Now, to a degree, that's true. You need to go through a huge application process. But once that data has gone to a private company, there is a caution about what they could do with it next. So that's another area we work directly in, having direct conversations as a patient group with companies about how they operate, what their technology model is, what data they hold about people, what extra things they do with it, to try and get a real grounding and understanding of that. And you've had involvement in some of those pieces of work, haven't you, Margaret?
Yes, yes, I have with some of the commercial companies, and perhaps I could really highlight the panel who met with Flatiron, and they were, a cancer-focused health technology company coming from the US, looking to impact in the UK, and there were a group within our PPIE group and other outside people from like Use My Data, interested people came together. Now, the interesting thing, if you go onto the website, you'll read the blog written by the panel members. And the interesting thing was, it wasn't easy and it was tough questions. The initial bit, obviously, there is no area that is so suspect by patients and public than industry or commercial people using our data. And so and even I've heard Lauren Brown from Flatiron in a meeting saying about that trust had to be built up. And it was built up through tough questioning, through challenge questioning. But as the trust was built up, there became more openness, and the more openness came to more trust. And as a result, and that took both sides to be willing to be open and to be able to be transparent. And as that goes on, I would say to you, read the blog, but talks about the recommendations. And James has already spoken about some of those, the recommendations about moving forward. What was the risk level? What was acceptable? What was the impact? And those things now are being put into place. And through it, actually, within the PPIE group, they've looked at having almost like a template to look at what we would look at in relation to commercial partnerships, and what the things we would see and understand. Us understanding fair value can be very difficult, because fair value is was very abstract at times. So that's what a lot of our working within DataCan is really an understanding of what different terms mean.
Yeah, and interesting that one of the things you mentioned, Use My Data there, which is sort of tangential to DataCan, but it's something that Margaret and I and several others on the call have been involved with directly. That's a much wider group of patients, relatives and carers who are interested in the right things happening with data. One thing we've done within DataCan particularly is to try and give our members a really strong grounding in all things data. So we've run drop-in sessions, education sessions, learning pieces of work, to give them a stronger foothold to be able to they can have the conversations in the wider settings to sort of empower their voice. And the other thing I would mention is, Margaret touched upon, we need to give patients a voice to get people to do the right thing. Now, singularly, that's quite tough. Any one person can say something, but it's very difficult to get the voices listened to. And as DataCan, we're trying to empower that by acting as an organizational perspective. The wider world, from Use My Data side, the other thing we do with at least a dozen people on this call actually is coordinate responses to big national consultations directly from patient voices. So this spans DataCan, goes outside of DataCan, goes into the other hubs, goes across the UK, where we ask people their opinions. We represent those directly back to politicians, policymakers and others to give them a voice. So we operate in quite a wide variety of patient settings. And the last thing I was going to mention, Margaret mentioned the work we did with Flatiron, who said, what do we think of our business model? Now that fundamentally changed the way they think, the way they operate, and the way they've approached things. Interesting that we had another approach from an organization, a commercial organization, who had applied to a big national data controller for some data and had been turned down. Now they came to us and said, we don't really understand why we've been turned down, because we think we're doing the right thing for patients. So we put their application, their response from the data controller to the small patient group, and they said, actually, yeah, we agree. We don't think you need to do anything different. We think in this case, the data controller has got it wrong, And we've now written back from the patient group to that data controller to say, no, this is a good practice and we think you should be supporting it. So those are some really solid examples of how we've embedded the PPIE voice into what we do and what we want others to do as well.
Yeah.
I was.
Can I just think, Christy, I think that's so important right through all the commercial industry. But you mentioned earlier about people being risk averse, even within the NHS, you know, and a lot of us, we want our data to be used. I want my data to be used, yes. I don't want to be locked up. Some people might want to lock me up, but I don't want to be locked up. But I want you also to take care of me and explain what you're doing with me. Because I see the names, I don't see the faces, the names on this call. You care about people, and you're here doing this because you care about people. But each of the bit of data that you have is a person. I'm a statistic, but I'm more than that. So I really would encourage you in industry organizations have that patient input to share with the rest of the population what you're doing with my data, really.
Yeah, I think it's a good point. And there will be people listening in here who've got their own patient involvement inclusion piece of work. We'd be really keen to hear from you about how you approach these things, because Margaret and I work hard at this, but we know we don't get everything right, and we're both continually learning. So one question that for everybody is, if you think there are good examples of PPIE elsewhere, please do let us know. We're not proud enough to think we're great at this thing, but we need to continually learn. I suppose the last point, just before we come back in, was to highlight something around that's come up a few times about the way that people hear about how data is being used. Trust is difficult to build up, but it's really easy to drop. And people earlier on were talking about if something bad happens, then the level of trust goes down. It doesn't even need that. If you look across, particularly in England and now impacting other parts of the UK, as we've heard, the communications around what was going to happen with GP data, pooling it together in a national repository, which has actually been happening for years, was managed, well, it wasn't managed. There was no decent quality communications about it. And we had a webinar, which we were involved with a couple of weeks ago, and we asked the question about GP data, this GPDPR process of pulling data together in England at a national level. We asked the audience, how did you find out about this? And nearly half found out through the media. And we know the media tend to be a bit sensationalist, a bit negative about the way the data gets used. And I thought that was horrific. And that for me is where we need to get a much stronger organizational voice, and particularly a much stronger patient voice to say, when we want the right things to happen, this is the way we want it to happen. And these are the safeguards, as Margaret said. If I encapsulated that fairly, Margaret, before we stop.
Yeah, just that whole being trustworthy is much different to being, even having to build trust. Show us as patients that you are trustworthy in what you're doing. Yes. Excellent.
So I'm conscious of time. I think we probably need to draw our little chat to a halt. As you know, Margaret and I can talk for hours about this stuff.
Sorry.
I'll be more than happy to talk to other people offline about these things as well. So please do get in touch with questions or suggestions. But with that, I think I'll hand back to the chair, if that's all right.
All right.
Thanks, Chris, and thanks, Margaret. That's really, we could listen to you for hours as well, because I think those sorts of rich contextual conversations between public patient engagement representatives and their groups, and industry and academia and people involved in health data research, I think are really important. So that's fantastic. So now we've moved into the Q&A. So I'd encourage anybody to put any questions in the chat, but just to lead off actually, and I was just going to come back to a point both you made, Margaret and Chris, actually, around the NHS data strategy. And you said about the potential negative involvement of the media. Are there strategies that you think where we should involve the mainstream media to send that positive message? And are there things you think we should be doing, additional agencies that we should be contacting in order to really display that not only patient message, but the public message as well, as hopefully we're all in this together?
I think positive comms is really tough because the media like negative rather than positive comms. You never see a good news story. Well, actually you do. You see fewer good news stories in the media than you do bad news stories. Bad news stories are easy to write. I think the way the GP data stuff in England is being managed is pretty bad, because there is no comms on it. There's no comms management. You know, if you were launching a product in a commercial world, you'd have a communications plan, tell people what it's about, sell it to them, and none of that has happened. And I think it's because of fear and risk aversion, and probably because people want to drop behind the law and say, well, it's lawful to do this. But James encapsulated it really nice in a previous session we did, was, yeah, it may be legal to do it, but do people feel it's legitimate for you to do that? How do people feel about these things? That's where we need to get a much stronger patient voice to make the right things happen. And that is happening through DataCanner, through the wider work we do with Use My Data, to give people a voice directly to influence those things.
Yeah, I would just follow it up very quickly by saying, I said in the small group about being proactive. You know, if you're planning things with the use of data, explaining the use of data, and data works because if you work with a patient group and a public group who understand what you're doing, who are willing to share that with other people, people listen to people. And so it should be like a joint comms about things, but not reactive. But start at the beginning and say, look, isn't this brilliant if we understand how innovation comes from using data, but let's also show you how you can trust us, and what does and what doesn't happen. So I would just think proactive, but make sure that patient and public voice is part of it as well.
Thank you. I think perhaps we need to contact Horizon or someone like that to start off some of these, as you said, the conversations that promote trust. And actually, I think that list of questions that came out of the feedback from the breakout groups, I think is really important to capture, you know, some of those concerns of researchers as well as industry. So one of the things I just wanted to pick up, I'm going to move on. I have got a question for you, Monica, and James as well. But I just wanted to talk about the risk. We talked about risk-averse organisations. Are actually any of the panelists aware of where we've captured the risk of not using patient data? And is that a way of promoting engagement? You know, what are we risking if we don't utilise this?
So I remember about 10 years ago now, working on the National Cancer Strategy with a great guy, amazing guy, Mike Richards. And he and many others worked out that the UK had quite bad cancer outcomes, and they were unexplainably less good than other kind of comparable, rich kind of European countries. And so we got to the point where we'd realized that was the case. And then in the room, we say, well, why is that the case? And nobody knew. And we said, well, where's the data? And we said, we can't access the data. We don't know whether this is because we're treating people differently or because we have different staging. And therefore, you've got the people who are influential and can change how cancer is being treated in this country, who can improve it. And they didn't have the data that allowed to tell them, we need to worry about surgery or radiotherapy or early detection or this. And that shocked me, and that's really driven me to do what I've been doing over the last 10 years. We can't go into this blind. So that's an example from 10 years ago. There will be many, many more.
Yeah, I mean, I would just reiterate what James has said. As with any organisation, you wouldn't expect to not know what's happening at each sort of part. So why would we sort of not do that, you know, in the NHS and across health and social care, where we're actually talking about people's lives? I think with digital transformation over the last few years, and in particular right at the front line, having worked as a CIO in an acute trust, you absolutely need to know every single thing that's happening in the hospital to be able to manage the flow, bed management, you know, dealing with people in A&E, making sure that all the right operations happen at the right time. And then essentially you need to scale that up. So population health management works best at place. So you need to take, you know, what's happening in the hospital and link that to what's happening in community services, mental health, across sort of adult and children sort of social care. not only for, planning and quality improvement, but for safeguarding, and these are absolutely at the heart of what we do. And then if you can extrapolate that up to a regional and a national level, then actually, we will get better understanding the pathways, understanding where the gaps are, understanding where the need is, and that's why it's so important in order to do this. You need that evidence base, otherwise you're just sort of shooting in the dark, really. And so it is very important. I'm going to hand over to Chris because I'm sure he'll say something about routes to diagnosis.
You can see I was itching to get in.
Fantastic example of where it has made a difference.
I might mention that. I was going to mention something else, which is we've seen in the past direct evidence where large-scale observational studies have had lots of trouble getting access to data. And what that study is trying to do is to demonstrate whether a particular intervention saves lives or not, essentially. Now, I know of a few which took 5 years to complete, and 18 months of that was a delay in access to data. At the end of it, the result of the study was, yes, we need to implement this because it can save 300 lives per year. By definition, then, if there's been an 18-month delay, you've lost 1.5 times 300. You've lost 450 lives because of those delays. So when we're looking at delays in access to data, then if we agree with the philosophy that data saves lives, which has cruelly been nicked by the UK government for their strategy, but if you believe in that philosophy, then surely if we're not using data, we're losing lives. And it's not that difficult an assertion to make. It's quite I think people stray away from those arguments because it comes across as quite negative, but that is the reality. If we have delays in accessing data and the resultant study shows we could have saved X number of lives, then we should equally be shouting about that and saying, this is where the improvements need to be made. This is where we're going to save people's lives by using data better. And it isn't just about living it on a bus or losing it or hacking. There is a positive side to this.
Perfect. Thank you. I think that's really insightful. And I'm going to move on as well, just to pick up on that. So you talked about an 18-month delay there, Chris, in accessing the data. And one of the things that I'm conscious hasn't really been mentioned here, but I'd be really interested to understand, and it picks up on a point that Monica made about digital transformation in health services, is the current workforce of the health service, even if you put aside the fact that they've been overwhelmed with dealing with COVID. But even before that, I'd really be interested in comments from everybody on the panel here around, are the workforce in the NHS now equipped to understand how to access this data, or even how this data could be utilised in their everyday service provision, etc. Just to, the final point really, I think, was that you also, I think it was, I can't remember who mentioned it, I think it was Monica mentioned that a lot of the data is behind a firewall, so the NHS gets access to all of the insights. But I think that means then that all of that data analysis, the interoperability, the logistics of that data is also the NHS's responsibility. So do we have the right people in the roles, and what do we need to build in the future?
Yeah, I'm happy to pick that up. I mentioned in my presentation that this isn't all about the tech. It is very much about the people, and making sure that they know how to use it. And also, once we've got aggregated data and it's fully anonymized, then that should actually be shared sort of publicly. And that's certainly something that we in DataCan are driving forward with our real-time data network. So I think it is very, very important. Across the Yorkshire and Humber, as part of our YHCR programme, we've set up an academy. So we've done one cohort of running through that. So that's not just analysts, that's actually clinicians, managers, leaders, to understand how to use the real-time data that's coming from our shared care record for population health management and beyond, into sort of the research domain. And we're working with Health Education England in order to extend that, not only for population health management, also for the shared care record side of things, so that we can upskill our workforce. I'm expecting that over sort of a 5-year period, we'll have up to 200 absolute real experts who can then cascade that knowledge share, but also go back to their organizations and work with colleagues in order to be able to use this in the most sort of effective way. And it's a bottom-up approach as well as the top-down in order to give that. And a lot of analysts want to work on these kind of things. They don't want to do the handle turning, the wrangling of the day-to-day data that frankly can be automated nowadays. They want to be able to do that sort of, proper insight. They want to be able to look at predictive analytics. So let's give them the opportunity and the skills in order to be able to do that, and then we'll all benefit from it.
Monica, how do people get involved with that academy?
Well, there are details on our website, which is the yhcr.org. We're going to put out a call for applications literally in the next few weeks. So watch out for our social media sort of feeds. But yeah, just go to yhcr.org and we can sort of take any applications and see where it goes from there.
Brilliant. Any other panelists wanted to come in, I guess, almost around the NHS workforce and some of the things that we need to implement in order to help them understand how to use data better or access data and remove that bottleneck. Chris, you unmuted. I don't know if James, you can, who wanted to come in there?
Okay, I'll start then. Just a very quick reflection. There was an adjournment debate in Parliament the other week about the GP data for planning and research. And the MP who was starting the debate was very negative about a few things, risk and things, but particularly he picked up on, why do we want commercial companies needing to use NHS data? We can do it all. And I think that argument is, in my view, is a bit flawed, because we need to recognize where expertise sits, and we need to develop a partnership way of working which is acceptable with patients, which they feel in control of, and from which everybody benefits. So it's not just about NHS being fleeced by commercial companies, but it is about, there is a partnership to be had where we can get mutual benefit with a real focus on it's been around patient benefit. So it worried me a little bit that simplistic debate was being had in Parliament to say, should work with industry, shouldn't work with industry, very polarized. And the answer is somewhere in the middle. I'm running Microsoft Windows. I could write my own operating system if I wanted to, but I don't, because they're better at doing it. And that's a relationship there. So I think there are ways we can work with commercial partners, which is heavily what James is focused on doing with DataCan.
Yeah, I mean, that's absolutely right. In Monica's presentation, she mentioned the 5 safes, which is one of the ways we can make sure that the way we work with data is safe. And that 5 safes doesn't say anywhere, you're not a commercial company. It's how you work with the data. That's the really important thing. How do you make sure it's private, it's secure, it's all those sort of things. So I think what we can do is move beyond, as Chris has said, this kind of false idea of commercial, non-commercial. There are some really talented people out there in the NHS. There are some really talented people out there in the commercial world. Why should we tie one of them down and say we can only work with the other one? That doesn't really make sense. We need to make it safe and secure for both to come in and do the research that will bring together the new products and the new treatments.
Brilliant. Anyone else? Margaret, did you have a perspective at all?
Yeah, well, yes, there's probably a very different perspective, but
Yeah.
I agree with the previous speakers. I think there has to be that whole understanding of data and the impact of it. We're back to, I've said it often, data saves lives, and it does. Data decided my treatment from my cancer diagnosis. So, we will never change things unless there is a way to share and educate people about using that data, whether they work in the NHS, whether they work within industry. But it's vital, because we all want excellence in health and social care. That's people in every area of the population. And without using that data to enable research and innovation, then we'll never have that excellence in health and social care. So I just would say that whole education that Monica's talking about is so important, but educating the public as well and how important it is.
Yeah, absolutely agree, Margaret. And I think it comes back to education and comms and specific comms potentially for the public, for industry, but even politicians as well, so they're not polarized and they really understand the intricacies of this, because it's not something I think you can just pick up and make a quick decision on. There needs to be considered approaches there. So I think that's hugely valuable. It makes me think perhaps we need some additional investments in the comms side of it to get the DataCan message or the wider HDR UK message out there, and also educate not just the workforce of the NHS or patients, but actually more broadly. Perhaps it should be in schools to educate us or something like that. Okay, we've only got a few minutes left. The final thing I was just going to say really is I think everybody on this call is really, if they're not already involved with HDR UK, is thinking about how they would get involved and what you're particularly looking for. So I'm going to come to each of the panelists really and just ask you, if you're a researcher or even a patient or industry, how's it best to get involved with DataCan or more broadly HDR UK? Where do we go? So I'm going to come to I think Monica first.
Right. The first port of call is the gateway. Certainly see what's there, what's available. There's a whole richness of information. So I would encourage people to look there. Any of the data sets that are within our sort of portfolio, there's an automatic link to our generic email that will then come through and be triaged by our business unit and under Chris's fantastic leadership to make sure to see if it's just a pass through directly to the data controllers or whether it's something that we specifically sort of have access to, and we do an impact analysis on commercial and non-commercial sort of requests for data, and we have a consistent process across the board. But if you have a more general question, then once again, through our contact details are on the website. I think we'll be posting the videos of this up on our website as well. Yeah, I just encourage people to keep in touch. Thank you.
Fantastic. Monica, it'd be great if you could just stick some of those links in the chat as well if people do want to go to those. That'd be good. I'm going to come to you next, Margaret, I think.
Yes, I suppose I would say to patients, members of the public, go on to the Health Data Research, the DataCan Hub website. Look at the aims of DataCan and in having that high quality data sets and the impact that then has for researchers to be able to know how to access them and do their work that benefits society, benefits the NHS, benefits patients, but also to see how the things are transparent. I think that's the secret to trust. The good transparency, good governance, accountability. And so I would encourage people to go on to have a look, to see, then to ask questions of any of the HDR UK DataCan staff or any of the PPIE group. But the work is there, and I believe in what they're doing will benefit people. So come on and look and join us and see it.
Thank you. Chris, have you got anything to add from patient public engagement perspective?
Just what Margaret said, really. If you're interested or your family and friends are interested, get in touch. The email is on the website. We can point in the direction of how to become more involved with what we do, or from a wider perspective, how to become more involved in what patients' voices do, or even if you want to be more passive and just keep being told what's going on. We can set all those things up, but I would encourage people, whether you consider yourself a patient, a professional, a carer, get involved with this data space, because we're going to need your voices, I think.
And finally, James.
Yeah, thanks. I mean, in addition to the data services that we can deliver ourselves, which Monica has described to the gateway, we also spend quite a bit of time talking to commercial companies about how they can access other data that we're not actually involved with ourselves. So, for example, Genomics England is a partner of ours. There's other, the Hematological the Malignancy Research Network up in the north is a great data source. So we can also help you find other data sources if we can't help you ourselves. So I think if you're a commercial company interested in doing ethically approved data science in the UK, please do give me or Phil, who's the commercial manager, a buzz. Our emails are on the chat. And just, you know, as well, we are very happy to enter into confidentiality agreements. Those confidentiality agreements will never exclude patients, unfortunately. We can exclude everybody else, but not patients. The patients have to see everything. And if you are a competitor of IQVIA, we can exclude IQVIA as well. So we can be completely private, but the one group that sees everything will be the patients.
Perfect. Thank you ever so much for your participation here. I want to give my personal thanks to everybody here on the panel and the speakers, and also Mark Rawler, who had to drop off earlier. I'm going to hand over to Helen now, who's just going to wrap up the event. So thanks.
Thanks to HDR UK and the DataCan team for such a wide-ranging and informative agenda this morning, and the 2 hours has certainly flown by, I'm sure you'll agree. We've heard from the clinical, technical and industry perspectives, and with that all-important emphasis on patient involvement and citizen trust in the use of population health data to enhance cancer research, improve outcomes and drive innovation. And to hear Margaret say that data saves lives is truly powerful. The progress that DataCan's made in only 18 months is impressive to say the least, and likewise only 12 months for HDR UK North. We've certainly heard how intersectoral and cross-regional partnerships can drive an enhanced research and innovation agenda, not just in cancer, but across the other data hubs also. So if I can just conclude really with thanks to Professor Mark Lawler, Monica Jones, James Peach, Chris Carrigan, Margaret Grayson, Joanna Clayson and Emily Balderson for preparing the content and organising this event. And I'm sure I speak for Joanna myself on behalf of the Life Science Cluster organisations, that are Hirani for Northern Ireland and the NHSA for the North of England, to thank you all in the audience for engaging with us all through this event. We'll stay on the VC here on Zoom until past, so please feel free to stay online for any final informal chat, or do contact us through the email addresses on the screen. And thank you all.